For those of you who haven't used a lot of GoToMeeting, it's a pretty easy computer system to use. If you do have questions from any of the groups and you feel like we can't hear, maybe you've accidentally been muted or something, or you've muted yourself, you can type anything in this little tab here, and I'll actually leave this open so we make sure that we're seeing anybody who's talking or has a question. We are GoToMeeting novices. So, and the goal for this kind of setup is I do give kidney rounds to the OSU residents every month. I feel that we have kind of a because we get a lot of kidney biopsies, with at least in proportion to the other universities, it kind of seems selfish to keep them all to ourselves, especially when we can kind of share this information with other universities. And then the hope is that these other kind of specialty services and other institutions that have their own kind of areas of specialization can do their own set of rounds of pathologic subspecialties. So the goals and the formats for this entire thing is really just to share what we know about kidney. We actually don't get GI biopsies anymore from OSU's hospital. Most of them end up going to Texas A&M for the GI lab. So hopefully we'll be able to see some of their GI biopsies and the classic lesions for GI disease, for endoscopic biopsies that would be coming from Texas A&M. I know that there are other universities, with NC State with liver, with Tufts, and having Sam there and his interest in lung pathology, Harvard having some background with primates, so things that we just don't get to see all that often we'd like to share. I think that the whole goal of this has got to be focused. We can't just all share and look at 5 different glass slides of glomerular disease and try to have one glomerulus. So point being, it's hard to kind of focus a discussion on this if we're all looking at different glomeruli and different sections of tissue. So that's kind of why I decided a panel might be good, because it's really going to target the types of lesions we're discussing. And so some of the topics that we'd like to talk about would be ones that have advanced diagnostics, obviously through kidney. That speaks to special stains that we do with kidney. It speaks to using EM and immunofluorescence for kidney. For other things would be things that have specific scoring systems, so as in GI, using the WSAVA scoring system for endoscopic biopsies, maybe lymphoma grading systems, those kinds of things, and then also organ systems that have their own specific terminology, and that, again, plays well to kidney. And everybody can hear me, correct? I'm going to look and see if anybody has any other questions. Everybody's okay?
Yes.
Okay. So that being said, I do have a very, very quick set of PowerPoint slides just for people who don't have routine special stains for their kidney evaluations. And all of this will be available for you on Dropbox at the end of this session. The first question is, why do you do all these extra steps? Well, in my opinion, and having looked at, I guess we have over 1,000 kidney biopsies in the WSAVA sponsored database through the International Veterinary Renal Pathology Service. And so I've looked at a lot of kidney biopsies. I also did a 1.5 years at UNC reading human kidney biopsies. So these are my perspectives on what you can get from each special stain. For H&E, I really think it's probably only good for assessing tubular injury and interstitial inflammation. I really think it is almost pointless for looking at glomeruli. So if you have a dog that has proteinuria or some other evidence of glomerular disease, maybe red blood cell casts in the urine, and you're only evaluating with H&E, I think you're doing a disservice to that patient. And you should at least do my favorite stain, which is the PAS. And don't do it just because it's my favorite stain. I just had to say my favorite stain there. So the PAS is going to help you evaluate the glomerular basement membrane. And I did send out copies of the publication that we had in JVM Supplement that has some of these discussion points as well. But it's going to help you evaluate the glomerular basement membrane and look for thickness of the glomerular basement membrane. It's also going to really help you localize where those cells are in the glomerulus. So sometimes with the H&E, the podocyte cytoplasm kind of blends with the glomerular basement membrane, and then that blends with the mesangium, and there's just so much overlap that the PAS is going to help you kind of clarify it. Are you looking at podocyte cytoplasm? That's going to be paler than the GBM. Endocapillary cellularity is actually going to look like it's in a lumen. Mesangial hypercellularity is going to be within a matrix in the mesangial matrix. So it's really going to help you localize where those cells are. The PAS is important for evaluating the brush border, especially of the proximal tubule. With early acute tubular injury, that brush border sloughs, and that would happen even before you have full-blown acute tubular necrosis. You would just have sloughing of the brush border and it would be gone. And those patients can be severely azotemic only with loss of the brush border. So sometimes that's your only hint that you actually have tubular injury. It's not full-blown necrosis. It's not coagulative necrosis. It's just sloughing of that brush border, and those patients will be severely azotemic, and that can be consistent with each other. I also look at the PAS to look at the basement membrane of the tubules. If it's really thickened, that means that tubule is atrophic and it's not going to come back. So basically, no matter what you do to help that patient, those tubules that have a thickened basement membrane are gone. So if pretty much every tubule has a very thickened basement membrane, then that's a poor prognosis for the patient. And then going back to the glomerulus, the PAS highlights hyalinosis and glomerular sclerosis. And I'm just going to check and see if anybody has any questions, and it doesn't look like we do. And speak up for those of you who actually can talk and have microphones as well. Please speak up. The next sections or next special stains are the trichromes. The trichrome, and I think you can see in the JVM paper that I sent around, sometimes you're lucky enough to see the deposits on a trichrome stain, and they are red nodules. Usually, this would be in the setting of having a membranous pattern. So these red nodules are going to be on the abluminal surface, so away from the capillary lumen. And you should see regularly spaced small red nodules if you're going to make that diagnosis via histology. Occasionally, we'll see deposits that are actually subendothelial with the trichrome, but that's more of a rarity. If you're going to see them, it's usually going to be in the setting of a membranous glomerulonephropathy. So sometimes you're lucky enough and you can make that diagnosis based solely on histology, and there have been quite a couple of cases where I've told the clinician who has submitted the biopsy that we can call it on light microscopy, and if your owner has financial constraints, or you want to go ahead and immediately start treating before we get the EM back, we can diagnose it solely via histology, and that's helped a couple of our patients. And it's also saved some clients money. Again, the hyalinosis and glomerular sclerosis can be highlighted with the trichrome stain. And then also the best thing for the trichrome stain is really look at that interstitial scarring. Sometimes when you have tubular interstitial disease, it'll actually just be edema. So when you're looking at the trichrome stain, you see separation of tubules, and it's kind of a light blue matrix. And you don't want to overinterpret that as being collagen. You want to characterize that as edema, because the edema can go away. But if it's dense blue, it's going to be collagen, and that's not going to be, that is irreversible change. So again, kind of characterizing what's going on in the interstitium. Is it more edema or is it more collagen deposition? The Jones stain, I've had a couple of people ask me why we always do a Jones and not any other silver stain, and I don't know exactly how this stain differs protocol-wise from a GMS, but I do know that a Jones has to stay in the silver for quite some time. And so that silver stain is actually, or the silver method is actually getting impregnated into the collagen. I think that's the word I'm supposed to use for that. So the Jones stain is really going to help you evaluate remodeling of the glomerular basement membrane. And if you don't have a good quality lab that does the Jones well, it's probably not worthwhile to do it. We had, I think our histo lab director is here, and we had maybe 2 weeks of practicing, and then once we got our protocol, we really liked it. It worked really well in our lab. So make sure you have a good Jones before you start trying this on your own. But the remodeling that we're going to talk about are spikes of glomerular-based membrane material, holes, which are representing encircled deposits, and then double conjuration, which is also going to be a response to immune complex deposits. So, and we'll look at some of these examples as we go through this kind of set of panels. And then the other key is that if you should have a black mesangium, the mesangium should take up the silver stain. And if it doesn't take up the silver, then that suggests that there's something in the mesangium that shouldn't be there. So whether it's deposits like immune complex deposits or fibrils or whatever, but that's a really good way to detect that there's something in the mesangium that shouldn't be there. Any questions? That's kind of the end of the special stain talk. Any voice questions versus typing questions? Is everybody still able to hear? Just kind of yes or no?
Yes.
Okay. I know I'm talking kind of fast. That's one of the issues that people have with me. So please clarify. This is pretty informal. Okay. Then just the other kind of reason that you would do advanced diagnostics for kidney, for transmission electron microscopy and immunofluorescence, this is really to detect the presence or prove the absence of immune complexes. So in kidney, knowing whether or not there's immune complex disease versus what we just put into a broad category of non-immune complex disease is really going to guide the therapeutic decisions for the clinician. So we can immunosuppress for immune complex glomerulonephritis, and then the risk is that if you just immunosuppressed everybody, you'd be giving a lot of pretty aggressive therapy, and it's not just steroids, it's mycophenolate, cyclophosphamide if it's really aggressive. So we're giving pretty aggressive treatments in these patients with immune complex disease. And you wouldn't want to give a patient with amyloidosis that type of treatment because it's a risky treatment, it's expensive, and the patients aren't going to likely benefit from it. So the issues is that when you have very early disease and some immune complex diseases like membranous that are very early, they're going to look completely normal via light microscopy, to the point where they actually look like very beautiful glomeruli. And everybody's like, oh, look at how gorgeous these glomeruli are. And then I go to EM and I find immune complexes on the outside surface of the glomerular-based membrane. So if you didn't do EM, you would have said these are completely normal glomeruli. This patient doesn't have immune complex disease, and the patient wouldn't be treated appropriately. Similarly, if you have immune complexes in your mesangium, sometimes it'll cause expansion of the mesangium and even sclerosis of the tuft. So, and I apologize for some of the residents that haven't seen this FSGS acronym, but it stands for focal segmental glomerulosclerosis. I need to make sure I define my acronym, so I apologize for that. But so what it means is that a part of the glomerular tuft is sclerotic. So some of these diseases can overlap via light microscopy, and that's why you really need either immunofluorescence, hopefully immunofluorescence, and EM to really delineate which ones of these are mediated by immune complexes and which of these are non-immune complex mediated. And the paper at least tries to kind of delineate that those are the two big branches of diseases we see in dogs.
And let me throw in that the review that we did, 500 cases of suspected canine glomerular disease from North America, in round numbers, 25% of those cases required EM and or IF to either prove immune complexes that were suspected or even unsuspected but nonetheless present, or disprove them sometimes when they were called on the basis of light microscopy or at least suspected. And although she mentioned amyloid, it's not amyloid that needs that. So
right.
Even the amyloid cases, albeit one that we picked up a very mild one first with EM and then went back. But it's not the amyloid cases that are the problem, and a quarter of all the cases required EM or IF to get the right answer.
Right. And so some of the other things as pathologists we kind of want to know, is the location of deposits going to tell us anything about etiology? Is it going to tell us something about prognosis? We see a lot of, not a lot of, but we see a proportion of our cases that have really abnormal GBM, whether or not it's type 4 collagen mutations that have been documented, and we have a lot of colonies of Alport's-like disease or hereditary nephritis, but we have some dogs that have abnormal GBMs and we can't figure out why. And then also, if it's something that might be hereditary and you need to know whether or not it's maybe an abnormal GBM, this will help you with the phenotyping if owners are deciding to breed or not breed dogs. And then this is exactly what George was just mentioning, the paper that came out with the JVIM supplement. So it was, I think I sent it out to you guys with the consensus paper. But we looked at cases that were submitted for the clinical indication of proteinuria. And George said a quarter, it's within 25 to 30% of cases that required EM for the definitive diagnosis. I'm getting better at not misdiagnosing. I'm better at correctly diagnosing, I guess. I think that sometimes when I started 5 or 6 years ago, I would see a couple of little red dots on the glomerulus on the trichrome, and I'd be like, oh, it's membranous, and then we would go to EM, and it turned out it wasn't membranous. And I think it was because it's probably a little bit of podocyte cytoplasm, and it wasn't regularly spaced nodules on the abluminal surface. So I think that even a novice who is excited can overcall things, and so that's why TEM actually helps you back off. If you know you're going to have TEM anyway, you're going to be more likely to say, let's wait for TEM. And so, but I do think that this does show that TEM is required, and this is actually in line with what they see in human medicine as well, about needing advanced diagnostics, whether it be IF or TEM for the definitive diagnosis. And I'm going to check for questions really quickly. No questions. Okay, so, and just a quick aside, so when we do immunofluorescence, it's actually very valuable in human nephropathology. It is confirmatory in veterinary nephropathology at this stage. The reason it's so valuable in humans is that they get the IF usually the same day the biopsy is submitted, so they can tell within 8 hours of getting the biopsy whether or not it's immune complex mediated. Our turnaround time is, I think, now at like a week and a half. So it's a little slower in veterinary medicine, which is obviously understandable. But the other reason it's really important in human nephropathology is that they have a lot of very specific dominant phenotypes. So they have an IgA dominant immune complex mediated disease. They have an IgG dominant immune complex mediated disease. They have a C3 dominant immune complex mediated disease. We've seen IgG. There have been reports in the literature of C3 dominant glomerulonephritis in dogs, and there is a report, I think, out of Korea or Japan of IgA dominant glomerulonephritis in dogs. At the IVRPS, International Renal Veterinary Pathology Service, we haven't seen these phenotypes, but that doesn't mean they don't exist. It's just we haven't seen them yet. So we may eventually start to see these kind of dominant phenotypes, and maybe they're breed-related or location-related or whatever, but I think we do need to do the immunofluorescence to make sure we're not missing any of these phenotypes of C3 dominant versus IgA dominant. And then also in human medicine, they have anti-GBM disease, and so if you guys think back to your second year pathology class where people talked about lumpy, bumpy immunofluorescence versus linear immunofluorescence, linear immunofluorescence is the antibodies actually targeting the glomerular-based membrane itself, and this is anti-GBM disease in humans. There are no documented cases in animals. There was one report, I think in Jevin Kennedy, it talks about one case report in a horse, but I looked at the paper and it actually isn't. The horse had no glomerular disease at all on histology, so it wasn't correct. It was, I think it was kind of overinterpreted, and that was from the 1970s. And hey, we haven't ever seen it again, and that's probably because it's not an actual disease in horses. So anti-GBM disease, I have not seen a proven case in animals. But in humans, the IF is going to tell you, is it linear or is it lumpy bumpy? And that's why IF takes a bigger role in human nephropathology. And so, yeah, again, the fact that we don't want to misdiagnose these kind of rare birds simply because we're not adept at our staining protocol. Okay, so we have, it took about the amount of time I wanted to. These are, I sent out 3 panels or links to 3 panels. And I sent out the 2 publications. I thought that for the first one, I would volunteer and give a description. I actually have a description written somewhere for this case, and I even kind of said what I thought would be valuable for points. But I thought this might kind of be a little informal way for us all to see how it is approached if you were to have a panel presented to you at boards exams. So is that okay for anybody, or was anybody dying to do this description? And then also before I ask that, is anybody have any specific questions about kidney special stains, immunofluorescence, or EM? Can you guys say you don't have questions so I can?
I don't have any questions.
Y'all make noise so she knows you're awake.
Yes.
Make no questions.
You do have a question or you don't? Oh, no questions. Okay, so I have to put my disclosure, I have never been on the board's exam, so I don't know other than how I was trained and how I would approach this. So that's my caveat, is this is what I would give for a board's description, but whether or not this is what the folks at Ames would accept or get mad at. But I think we can see within the panels A through D, there is serial sections of the same glomerulus and stained with H and E on A, PAS on B, trichrome on D, or C, and then D is a JMS. And I'm assuming for some of these panels, boards would actually tell you which stain is which. So in all, yes, so in all 4 panels, there is segmental effacement of the peripheral capillary loops by extracellular matrix. It's palely eosinophilic on A, it's PAS positive, it is blue on trichrome, and it is silver, or takes up the silver on the JMS. There is associated mild and mesangial hypercellularity. I think you guys can see my arrows here on the H&E. There's like 5 mesangial cells. And when we see more than 3, then we get a little concerned that there's mesangial hypercellularity. But please remember, mesangial hypercellularity is very nonspecific. It can happen with a lot of different types of glomerular injury. So it does not mean that it doesn't implicate anything about pathogenesis. That was an aside, my little comment about pathogenesis. That would not go into my board's description. But there is mild mesangial hypercellularity. I think you guys can see on the A and on B. Aside from that segment, the glomerular capillary loops are open. The glomerular basement membrane is of normal thickness. And specifically on the PAS stain, right here where my arrow is, that is a podocyte with protein droplets. And you guys can all see that on your screen, hopefully. Also on the PAS, we can see podocytes. So here's clearly a podocyte, here's clearly a podocyte, here's clearly a podocyte, and they are subjectively hypertrophic. Then, and I should also mention, this would go earlier in the description, that the areas of expanded matrix are adhered to Bowman's capsule, so that's a synechia. It's a pretty broad synechia. And then right here, this little globule of PAS-positive material is a focus of hyaline. So what that indicates is that plasma has insidated into the glomerular basement membrane. So we have hyalinosis, we have a synechia, and we have segmental extracellular matrix expansion. And I would actually even put in my description that that's, in parentheses, I would say segmental sclerosis. Yep, please. So, and it will. So the question for everybody on the computer is that how do we know this is hyaline, because it looks the same color as the glomerular basement membrane? And honestly, this is just shape. So if it looks globular, then it's hyaline, and it will be that same kind of color. And so.
You also get a hint down in the JMS in the same region where there's that sort of globular area of faint as opposed to dark.
Yeah. So yeah, so this right here, the GBM is taking up a lot of silver, and this area isn't taking up silver. So that helps. Okay, so yep. Okay, so the question was, would we describe the parietal cells as being hypertrophied? And I think, at least on the silver stain, it's a little more cuboidal than we would like. So I think putting it in there is fine. It's not incorrect. I don't know if I gave it a point, but I'll look at what I did for how I graded the thing. There is some lamination of Bowman's capsule basement membrane noted specifically on the trichrome stain over here and on the silver stain. And that's a lesion, as an aside, that's a lesion we often see in this area of synechia, or in glomeruli that have synechia. And I'll talk a little bit more about what we think that means. Okay, so histologically, we've talked about segmental sclerosis, we've talked about the synechia, we've talked about the protein droplets in the podocyte, we've talked about the hyalinosis, and then the fact that the rest of the tuft looks, although has mild mesangial hypercellularity, the glomerular basement membrane is not thickened. Okay, so then if we go to the EM, oh sorry, that was my phone. Okay, so if we go to the EM, we have multiple capillary loops, and I'll just, so that people can see, I wonder if I can, no, I think that's fine. Multiple capillary loops. This is urinary space, just to orient everybody, and then this would be endocapillary space here and here, and this would be mesangium here and here. The important thing for the EM is the fact that we have these broad regions where all the foot processes are effaced. If you're looking at an EM of a glomerulus and you do not mention the foot processes, that would be bad. That's one of the things that we all can see pretty consistently. Oops, sorry. So we have effacement of foot processes. You have these little tiny, tiny tendrils here, which is microvillus transformation. It's just what the podocyte does when it's injured. It makes little villi and sends them out everywhere. And then if you notice, the glomerular basement membrane is does not have any evidence of electron-dense deposits. And this is the important thing. When you're talking about EM, you want to talk about electron-dense deposits. You don't want to flat out call them immune complexes, because we can't tell that they're immune complexes. We can say electron-dense deposits. In parentheses, you could say suggestive of immune complexes, but right when you're looking at EM, it's electron-dense versus electron-lucent. Remember that. Yes. Sorry, oh, there is a question. Sorry. what are the requisite criteria to diagnose sclerosis in glomeruli? So sclerosis is anytime you have expansion, or sorry, let me rephrase that. So sclerosis means that you have effacement or compression of the peripheral capillary loops, and it's due to extracellular matrix. Mesangial, if it's just mesangial expansion, that's all I say. If you just see a normal glomerulus, all your capillary loops at the periphery are open and patent, but you see thickened mesangium or expanded mesangium, then I only say expanded mesangium. It's once those peripheral capillary loops are gone because of the extracellular matrix and or hyaline, then I say sclerosis. Does that help? Can you type in if that helps? Yes. Okay. Exclamation point. Yay. Okay. Okay. So in the EM, again, we have the podocyte foot process effacement. We have these little things here, which, and if you guys all looked at this at a higher mag on your own laptop and we're not looking at this huge computer screen, there are electron-dense areas in this mesangium, but the shape of this is such that it is not consistent with immune deposits. If you were to say that there's electron-dense material in the mesangium, that would be fine. Sometimes we see a little bit of mineral or a little bit of lipid get here in this disease process, and it's usually here. And so, when I describe it, would talk about electron-dense material, but I would not interpret those as immune complexes. And that's supported because if we're looking at the F panel, we have an IgM stain here, and we have this material that's segmentally present, or we have segmental staining, and I use the word splotchy. It is just kind of this globbed stain, and it's very non-specific staining pattern. And if you look at the other areas of the glomerulus, there's not granular staining. So this is non-specific staining that we see in this disease process. So if we think about right up here, we've got this hyaline here, we've got areas, we have hyaline here. These are not the same glomeruli, obviously. This one's histology, this one's IF. But we have hyaline exudation or incidation into the segmentally scarred segment. This is trapping all of that, and that's why you're seeing this splotchy appearance. So it's not just saying, yes, it's positive, it's 4+ positive. It's 4+, and the pattern is that of splotchiness, which means it's nonspecific. So if it were specific, we would see granularity. And we don't have any granularity on this glomerulus. So then my final diagnosis is that this is segmental glomerulosclerosis, and the overall disease process is likely focal segmental glomerulosclerosis. I couldn't say focal glomerulosclerosis based on the panel because I'm only looking at one glomerulus, but I think it fits into that disease category. Yes? Which panel E? Oh, so that's all podocyte. So the question was, yes, I'm a minute. So the question was, what is all this material here in the urinary space? And so remember, your podocytes are sitting here, and when you guys have seen stuff in textbooks, you've seen like the perfect cross-section of a podocyte with its amazing foot processes that are interdigitating with the basement membrane. So that's, you know, a fixed specimen. The rat was probably perfused with formalin, whatever. So seeing this degree or this kind of arrangement of podocyte cytoplasm is not abnormal in a regular diagnostic specimen. Sometimes it'll be extremely swollen and you can't even see urinary space at all, and all you see is podocyte cytoplasm. To me, when it's that swollen, I think it's indicative of podocyte injury, but we do have evidence of podocyte injury with that foot process effacement. Okay, so then just quickly, when we talk about focal segmental glomerulosclerosis, I like my little picture, so you guys are going to have to see it. Okay. So when we talk about focal segmental glomerulosclerosis as a disease process,
No.
ooh, oh, is that were you talking to one of your dogs, George?
Yes, the Luke wants to go outside.
I heard you say no in a very funny way. Okay. Okay, so human versus dog. So, the category of focal segmental glomerulosclerosis is going to be introduced as a diagnosis in Jubb and Kennedy in the next edition. The previous edition mentions it for, I think, 2 sentences, but it's actually a pretty common diagnosis that we make at the IVRPS, so it will have a much bigger discussion in the new version of Jubb and Kennedy. So for those of you who are sitting in September, you're off the hook and you don't need to pay attention. But I do think dogs represent an excellent model for spontaneous focal segmental glomerulosclerosis, which is the most commonly rendered diagnosis for proteinuric humans in industrialized countries, I guess I should say. So dogs actually represent an excellent model for this. There are 2 different kind of pathogeneses. One of them is a primary pathogenesis, or familial, sometimes they're called, and that's due to innate defects in the podocytes or in the slit diaphragm. Remember, you have podocytes and they have all those foot processes, but there's a slit diaphragm bridging one foot process to the next. So if you have a mutation in a podocyte protein or a slit diaphragm protein, I just made up the word slit diaphragmopathies, then your podocytes are going to be more likely to be injured by the normal wear and tear glomerulus experiences. And so they are more likely to have segmental scarring. And that segmental part of it is really important. If the reason, and I'm not sure why it would be a segmental pattern if every single podocyte has the same mutation, other than the fact that there are probably areas of the glomerulus that have different perfusion pressures or undergo different types of, well, I guess pressure, filtration pressure. So if it's near the hilus, that's going to have a higher pressure, or if you're near the tip, the urinary pole, that'll have a different pressure. And to me, that it's reasonable to think about that way. So as podocytes are injured, they detach. They can slough off into the tubules and then get urinated out. You can actually see podocyturia in humans with active disease or kind of ongoing focal segmental glomerulosclerosis. The neighboring podocyte will try to cover the glomerular basement membrane, and it can only do that for so long. There's only so much compensatory compensatory hypertrophy of the neighboring podocytes that can happen, and then they're going to get injured, and then you're going to start this whole vicious cycle again. And there is a publication that would be viable for this year's, I guess if they tested on mammalian genomes, but Penn did analysis of soft-coated Wheaten Terriers. They all had PLN clinically, and they did find specific mutations in 2 genes that are both podocyte genes. They're slit diaphragm genes. And so if you have one of these mutations, you're at higher risk for having PLN, and often the disease I see on biopsy is focal segmental glomerulosclerosis. So, these kind of track with patients that have proteinuria from that. And I mean, it's not like a UPC of 1, it's a UPC of 5, so it's significant proteinuria. So that's the kind of the primary familial ones. And then you can also just have adaptive or secondary focal segmental glomerulosclerosis, and that could be due to any kind of environmental stress. In humans, we know it's really associated with obesity and hypertension or arterial nephrosclerosis. If you had maldevelopment, you might have fewer nephrons than normal, and so your other nephrons have to grow in order to compensate, and like we said, you can only compensate for so long, and then you're going to injure your podocytes again. And so again, pets could be a good model for that because they actually share the same living environment, and often when you have obese dogs, you have obese, I know that's, I mean, but like you could have some kind of associated, you know, environmental characterization of that, so. And I just, you know, want to know that it's not a new lesion, it's just under-recognized. Everybody really knew what the lesion was, and they knew to call it sclerosis, but they often said that there might be underlying immune complex disease. And I think that was because sometimes you see a little bit of mesangial hypercellularity like we saw in our panel. So there is a little bit of hypercellularity. And so they might have misattributed it and said that the sclerosis indicates that there was previous immune complex disease. But if we pay attention to where the cellularity is located or maybe what the podocytes look like, then we can kind of help us get to the right diagnosis via light microscopy. But then again, you're still going to need EM or IF to definitively rule out the presence of deposits. And so again, this is just a different dog, but you have normal tuft here. So yeah, you have a podocyte that looks upset, but you know, this isn't hypercellular, this isn't too many cells here, and this area right here is sclerotic. So that segmental nature should kind of get you on the right track for this diagnosis. It looks like we have 50, we might be able to get through one more panel, which is an easy panel. So if any of my residents want to, I know I said I wouldn't call on anybody, but you have to talk into the microphone. That's the only key. Anybody? Anybody from the Outland? Anyone? Okay, so Shannon.
Yeah.
Do you know what this one is? You should be able to.
I can give it a try.
Okay, and honestly, I think that
No judging.
no judging. And so I'm just so this is Dr. McClelland. I can never say your name. McClelland.
Yeah.
And she's at Colorado State, so she's super early. It's 6:30 there, 6:45 for her. And she has an interest in kidneys. We work together a lot, and she helps with the service. And so I feel really bad putting you on the spot, but my residents are giving me I think they're more afraid of the microphone than anything else.
Okay.
So we'll have to practice.
I'll do my best.
Okay.
I'll do my best. Okay, so I see in panel A, which is the H&E, that we have some mesangial expansion. I do see a few open capillary loops. Yeah, that 12 o'clock spot. But it's mostly kind of homogeneous in that area. And then I guess on PAS, it's PAS positive. It's, you know, like I said, it's seems more like mesangial or matrix than cellularity. I think the cellularity is probably appropriate throughout the Guam. I maybe see a few hypertrophied podocytes at about 1 o'clock. Let's see, and then on the trichrome, it's trichrome positive as well. I do see in that area it's a little bit more pale, so I don't know if that's more indicative of protein or edema. I don't know, you don't really get edema there in Guam, so I take that back. And then it doesn't take up in the silver. So, yes, and then I'm looking at the EM, and basically this is a pretty high mag, so I'm having a little bit of trouble orienting myself. I think at the very top, so between, you know, 11:30 and 1, I think that's probably the uriniferous space.
Yep.
And then you have complete effacement of the processes. You can't even really distinguish them. And then I think kind of at 9 o'clock, that area is probably the endocapillary surface.
Yep.
And so what you're basically seeing is kind of this finely granular, I don't know if that's an appropriate term for boards, but I don't know if those are fibrils or if that's just finely granular within the basement membrane. You almost can't even see normal versus abnormal.
Yes, and I apologize. So I think for boards there would be an inset that would be a higher mag. So, and I think I meant to do that and then forgot to do it, so I apologize. But I think here you can get a little more impression that that's more fibrillar or fibrillar.
Yeah.
Like here you can see one fibril there.
Yeah, I think, yeah. So fibrils, and then the IF looks, no, I'm not very comfortable with IF, so I would say based off of the EM that this is a negative. I mean, it's not completely negative, but I don't think that this would scream positive for immune complex, my IF.
Yep, exactly. And so, and and this is the issue of whether this would be, so this is more of a lifestyle thing or like a life lesson that you're always going to see a little bit of hazy green. So that's like a life lesson. So even though if you just see a little bit, like if it's boards and it's definitely immune complexes, you're going to see the most beautiful granules you will ever see. But this is routine. This is from this exact case. This is the glomerulus from this exact case where we just saw this kind of hazy, non-specific staining pattern. Okay, so, and I did not give you the diagnostic stain for this panel, but what would you think that this disease is?
Amyloid?
Yeah, exactly. So the keys, I think, for amyloid are the fact that, like I said before, and I've said it a couple of times, the JMS isn't going to pick it up. It's not going to get, it's not agyrophilic or however, R-gyrophilic or however the word is. So the JMS doesn't pick it up. I think that there's a synechia here. I think there is an adhesion between this region, although that could be the vascular pole, so maybe I'll take that back. Maybe there isn't a synechia. That might be the vascular pole. So I completely misspoke. I apologize. So this hair is just expanded mesangium, like Shannon said, and I think when you were looking here and there was a little bit of pallor, and sometimes there was actually even a little bit of peach coloration. Amyloid often does that. It has kind of this mix here. Here you can see a little tincture of peach material, and amyloid does that on a trichrome sometimes, not always, but sometimes. So if it were really, really dark blue, then we would think, okay, that's probably more likely going to be collagen. But the fact that it's kind of got this haziness about us, I think tells us it's probably not exactly collagen, or not just collagen, I guess I should say. George, do you have anything else to suggest about this case?
If you look at amyloid cases overall, in general, you get an impression that that the PAS and the trichrome are, you can see suggestions that it's amyloid. It's not PAS negative, but it's not just the nice dark purple like the other places.
Mm-hmm.
And I don't know whether you're seeing my and again, the trichrome that often has, it stains, but it's the amyloid stains, but it stains with a little bit of a different tincture.
Yeah.
And one of the things that is true is that the way we cut our slides and things like that, we purposely make serial sections and have them stained with different stains so we can go back. And the beauty of this is that you get a collective impression
Right.
by comparing the same glomerulus or say almost the same region, the same glomerulus with different things, and you get a composite message from looking at all of them that is more informative than just picking any one. And then with the IF, I've always called the amyloid deposits often, especially with IgM, but also with the others, get what I call a blush kind of thing. It's sort of like the glowing cheeks of an embarrassed lady. It's not negative, but it's not this intense splotchy that we saw in the segmental sclerosis, but it sort of just blushes, and that's a common observation in the immunostaining of amyloid cases.
For dogs and cats, yeah. And so, this might actually help you kind of remember this, and so I will mention it. So the MDs talk about this appearance of the PAS, and sometimes the ones that have the tinctorial change in the trichrome, they actually call that waxy staining. And I think it goes back, at least according to Dr. Jeanette, it goes back to the day before they had histopathology, when you were doing autopsies on humans, and if they had amyloidosis, their kidneys felt like candle wax. When you took them out, you could stick your finger in it, and it would feel like you were putting your finger through melted candle wax, or not melted, but soft candle wax. So waxy has often been associated, that term has been associated with amyloidosis, and I think that's why they say that this is a waxy appearance to the PAS. And since we don't really have that same type of issue, or we don't have that same history, but I do think it will help you remember that on a PAS, it's going to look a little different than normal GBM. It's going to have a weirder or stranger appearance. And on the trichrome, it's not going to look like normal glomerular basement membrane or normal mesangium. It's going to have this kind of atypical appearance. And so maybe having that word waxy in your head isn't such a bad thing, because it'll remind you that that could be amyloid in there. Obviously, if this were a board slide, they would be cruel and not giving you a Congo red. The whole reason I did not give you a Congo red is because I made a whole bunch of panels, which we will be going through over the course of a couple of months. And I didn't want to have the one with amyloid being the only one with Congo red and flagging you guys like, oh, this must be the Congo red case. So anyway, or the amyloid case. And I do have, quickly, I have 2 extra slides about amyloidosis, or maybe just one, and then we can wrap up for today. Remember, amyloidosis in humans is actually often a different pathogenesis than it is in animals, at least humans that are from industrialized nations. If you're looking at developing countries, they actually have a lot of the same amyloid that dogs and cats do, because they have a lot of underlying infectious disease. So in dogs and cats, we often see a deposition of serum amyloid A, whereas humans from industrialized nations, you would see light chain amyloidosis in your glomeruli. So in those situations, you actually will see significant glomerular staining on your immunofluorescence, and it would be for your kappa chains or your lambda light chains. So IF can be very helpful in humans with light chain amyloidosis, whereas we don't see that in dogs or cats. I have not seen it yet in our biopsy service. Everything we've seen has been that blush staining that George mentioned, and so those are more likely to be serum amyloid A. And then the other discussion is that sometimes, and this is something that we see kind of consistently in humans, and we've seen it probably maybe 5 to 8 dogs that we've had in the IVRPS system. And so what happens, and I have a picture of it on the next slide, is that the amyloid actually starts to get deposited in the glomerular base membrane, and then there's these spike-like projections kind of in between that area. And so if you're looking on the JMS stain, you can actually see spikes on the glomerular base membrane, and you might confuse it for a membranous pattern or, response to immune complexes. So, and I'll show you what that looks like. So this is what happens sometimes. Here you have your capillary lumen. This is what is your GBM, or what used to be your GBM, and you have all this spikes of amyloid material kind of going radially out from the glomerular base membrane. I don't know why some of them have this phenotype versus the phenotype that's more typical, but we do see it. And so actually what happens is, if you looked at the silver stain, some of this would actually kind of stain silver, and I don't know why, but it does. And so you would see these little radiating projections on the silver stain, and so if you were only looking at the silver stain, you might confuse it for a membranous, but you would also have the fact that you had your Congo red on the same panel, and it would be an amyloid stain. And then if you did a higher mag, and this would have been something that I should have put on Shannon's panel, you would see these filaments at higher mag, and you guys can definitely see the filaments. And then remember, her boards, the diameter is 9 to 11 nanometers, not millimeters, nanometers, and that's the kind of the classic diameter that you would talk about for boards. Does anybody, oh, that's the next panel. Does anybody have any questions about amyloidosis?
Rachel, the spike appearance, would you think that that might make it likely that this dog has AL instead of AA amyloid?
Well, we discussed it because we were discussing whether or not, and I think this is the actual case that we were talking about with the WSAVA, and so because humans have this appearance often, they actually call it Roman helmets or coxcombs, or like rooster combs. That's their little terminology for it. And so we thought, well, if humans have this appearance and they also often have light chain, could this be light chain amyloid? But our IF for this case didn't actually support it, because you would expect to see very strong staining with the lambda or the kappa, depending on what amyloid it was, and we didn't see it on this case. So even though we had that discussion when we first looked at that case, and I think I even probably mentioned it even in the biopsy report when I wrote it up. Having spent a year and a half at UNC, I think that our IF didn't support it. Does that maybe, so yeah, so that's kind of how I feel about that. Does that help you?
Mm-hmm.
Okay.
Let me throw in two things for the young folks in the various rooms. There's lots and lots of room to go forward in veterinary nephropathology. Actually, it's kind of interesting. In human nephropathology, finding amyloid is the beginning of an intense investigation about what's the underlying cause, what is the nature of things, and whatnot. And in veterinary medicine, it's almost a stopping point. Because we have this sense that it's all amyloid A and we don't know much more about it. But ultimately, I think that there's more to be learned about amyloidosis in animals. And the other piece of this is that with the biopsy, sort of looking at proteinuria and things, we often find amyloidosis at a time, if there was a treatment for it, that it ought to be helpful. We half the dogs we've diagnosed aren't yet azotemic and things like this. So amyloidosis is, a big mosh pit right now of opportunity. And then the final thing is to go back just conceptually to focal and segmental glomerulosclerosis. That again is a pattern of injury. In people medicine, they have a in-depth understanding of a lot of different underlying causes and possibilities and things of that nature. We are in veterinary medicine as just at the beginning or front part of the discovery of the kinds of things caused, but more importantly, which are common and which are uncommon. How do you tell them apart and those kinds of things? And so we've come to the point of understanding that in our biopsy series, it's on the order of 20% of all the cases. More common than amyloidosis, and so there's a lot of figuring out to be done with that disease as well.
And I believe the case that you presented, Rachel, was hypertensive.
This case,
the first case.
Yeah. So and that's the other thing is the first focal segmental glomerulosclerosis or segmental glomerulosclerosis, that dog was hypertensive. So whether or not that was one of those adaptive pathogenesis that the glomerulus had started to scar down because of hypertension, or whether or not it was a primary post-stimulation. It's at this stage we don't know. We can just put it into the pattern of disease, and then we can start to see how these animals start to group together. Do you guys have any questions? Anyone else on the computer Outland?
No.
Okay. Was this at least helpful? I know that I talk quickly.
So we plan to do these things regularly. Feedback to Rachel.
Yes.
I know she would love to hear from you. You don't have to do it publicly necessarily, but a pat on the back for doing it well, or suggestions for improvement, or these kinds of things are always helpful. Everybody wants it to be better, and then if we get this down to a format that works comfortably, ultimately we will not just be able to do nephropathology from the people that are seeing those cases, but liver from the people who are seeing those, gut from the people who are seeing those, maybe bone or skin from the people that are seeing those, and enrich the experience of folks in various places.
I agree. And if you guys also think of stuff, we have it set up for our residents at the fourth Wednesday of every month at this same time frame, and our time frame has to be 8 to 9. That's required by our residency program. So I'm sorry, Shannon, it will always be at 8 in the morning, 6 in the morning for you. But anyway, so our time frame is the same. If you have questions during the course of the month and you're just thinking about something and you want to do, shoot me an email. We could do the first 5 to 10 minutes of answering random thoughts that came across your mind as you were waiting in between Ask a Friendly Pathologist kind of questions. I am friendly. I hope my comment about shouting wasn't taken the wrong way. I don't shout. I'm just a loud talker. Okay, is everybody okay?
I bite, but Rachel doesn't. All right.
Thank you so much for joining.
All right. Thank you, everyone. Bye-bye.